we're privileged to have Dr. Elizabeth Pringle join us today. For those who did not have the pleasure of meeting her before, I'll give you a summary of her accomplishments and her career path. Dr. Pringle grew up in beautiful Rocky Mountain of Alberta, specifically Banff, where she studied and obtained her Doctor of Medicine at the University of Alberta. After a short time as a family doctor, she did a residency in internal medicine at the University of Calgary, followed by neurology residency and fellowship in multiple sclerosis at University of Western Ontario. Her interest in neuromuscular disease brought her to do a fellowship at the New England Medical Center in Boston. She came to the University of Ottawa in 1994 to head the EMG lab at the general campus of the hospital and has been in Ottawa ever since. She's headed the Myasthenia Gravis Clinic of Ottawa since 1995 and has been involved in many clinical trials in myasthenia over the years. In 2014, she was named a distinguished teacher for her contribution to teaching at the Faculty of Medicine of the University of Ottawa. Apart from her keen interest in neurosciences, she enjoys her beautiful garden and occasionally foists homegrown tomatoes and garlic on her unsuspected patients. She enjoys cooking and has been known to enjoy a sip of wine or two while cooking. She also plays guitar. She says she stays badly, but I think that we're going to have to be the judge of that. Dr. Pringle, you'll have to come back and serenade us.
There will not be a concert.
She also is a dog mom to a rambunctious Australian shepherd named Scott. So with all of this, now that you know a little bit about her, I'd like to welcome Dr. Pringle. And again, thank you for being with us today.
No, it's my pleasure. Now that I've already done a couple of disclaimers, I'll do another one. I'm on a very wobbly table here. So if your screen starts blurring, it's not your myasthenia, it's my table bouncing around. And if you start to hear kind of whining noises, it's not me, it's Scout, my dog. She's very upset at me for closing the door here. So, so we'll see if we can share this. It worked before, will it work again? There, can you see that?
Yes.
Okay. Well, I saw a lot of familiar names and faces in the gallery there. So I apologize in advance because most of what I'm saying is probably going to be very familiar and probably boring to my patients because they will have heard me say it multiple times. But Michelle was, she gave me quite an assignment. She wanted really everything about myasthenia, what it is, how to treat it, and what's new. So that was a lot to cover in less than an hour. So I hope I've been able to do it. We'll start with what it is. And it's really right there in the name. In Latin, myo means muscle, and asthenia means weakness, and gravis means serious or severe. So severe muscle weakness, it's right there in the name. It's an autoimmune disease, so it's probably better termed autoimmune myasthenia, although we hardly ever call it that, mostly because that word myasthenia can appear in other diseases that have nothing to do with autoimmune myasthenia. So generally, when you hear someone talking about myasthenia, they're talking about autoimmune myasthenia. So what's an autoimmune disease? Well, these are the diseases where your own immune system attacks parts of the body in the mistaken belief that they're foreign. So it's kind of like your immune system having a case of mistaken identity and attacking your own body. And depending on which part of the body is the target, different diseases come about. So if it's the joint lining, you unfortunately get rheumatoid arthritis. If it's parts of the thyroid gland, you can have Graves' disease or Hashimoto's, blood vessels, vasculitis. You can see down there at the bottom, something called the neuromuscular junction is why people get myasthenia gravis. So what on earth is the neuromuscular junction? Well, again, as the name kind of implies, it's where the nerve and the muscle meet. So the way the system works is your brain sends a message that it wants to contract one or a series of muscles, and it sends the message through the central nervous system down to the spinal cord. and then out into the peripheral nervous system via the nerve cables of the peripheral nervous system. And down here, where the nerve and the muscle meet, is the neuromuscular junction. And if you do a close-up on that, those of you who are my patients will recognize this extremely artistic drawing that I draw for all of my myasthenia patients when I first meet them. And that's the neuromuscular junction. So you've got your nerve and you've got your muscle, and it's now becoming evident why I'm a neurologist and not an artist. And when your brain says, okay, I want to contract that muscle, a little electrical impulse goes down the nerve cable. And when it gets to the end of the nerve, there's these little bubbles of a chemical called acetylcholine, or ACH. And when that electric signal gets to the end of the nerve, the ACH is released rather into that junction, and it floats over to the muscle where there are receptors for it. They're kind of like the ignition for a car. So when the chemical acetylcholine interacts with the receptor, the muscle contracts. So that's how it's supposed to work. In myasthenia, what happens is your darn white blood cells, part of your immune system, and specifically a subset of them called lymphocytes, they get this mistaken identity message, and they start recognizing that those ACH receptors are foreign and they don't belong there. We're not entirely sure why that happens. There's lots of interesting theories, but anyways, they identify it as not belonging there, so they set out to destroy it, and they do that by firing these little missiles at them, and the missiles destroy some of the receptors. The missiles are called antibodies, and you can measure those antibodies in the blood. Probably about 85% of myasthenics have an antibody called the anti-AChR receptor, and about 10% have something called the anti-MuSK receptor. And you can see that that's going to leave about 5% of you out in the cold. And those are the group that we call the seronegatives. Now, when I first started giving this talk, it used to be about 20% of patients with myasthenia were seronegative, and now we got it whittled down to about 5%, maybe slightly more. And there are a whole bunch of other antibodies, which if you spend tens of thousands of dollars, you can usually identify an antibody in most seronegative patients. But the ones that are easily checked for are anti-AChR and anti-MuSK. But they do the same thing, so that when those receptors get destroyed or blocked, not as much activation of the muscle occurs, and so you get muscle weakness. Now, it's a little more complicated than that, but I actually like this diagram, and that's why I draw it for every poor patient that comes through, because it's a handy way to look at the system. So what are the symptoms of myasthenia? Well, muscle weakness. That's really the one and only symptom of myasthenia. Exactly how that manifests depends on which muscles are involved. So our first pertinent negative is that myasthenia does not cause sensory symptoms. So if you've got numbness or tingling or major pain, that's not myasthenia. Now you can get pain in myasthenia sort of as a secondary effect. Let's say you got a bad back and some of your back muscles get weak, that can make the back pain worse. So in that sense, you can have pain as some component of myasthenia, but it's not a primary cause. So if that's the main symptom that people have, we tend to go looking for other causes rather than just myasthenia. And myasthenic weakness, as I'm sure you all know, is a very specific type of weakness. It can affect any muscle, and there's an asterisk there for a reason. I'm going to go back to that in a minute, or combination of muscles, but it most commonly affects the eye muscles. So the two main ocular or eye symptoms are droopy eyelids, which we call ptosis, or double vision, which we call diplopia. And next most common are these bulbar muscles. So the bulbar phrase is a kind of a funny throwback to a historical time. It's a part of the actual brain that when you look on an autopsied brain, there's this little bump down at the bottom that looks like a bulb. And nowadays we call it the medulla. But from that part of the brain come the nerves that supply the face and the jaw and the swallowing muscles. And so we call those bulbar muscles, and you'll hear or you'll see in my clinical notes that I'll comment on whether or not you have bulbar weakness. So that's those muscles affected. And it's the second most common way for myasthenia to affect people. And then, of course, it also affects arms and legs. And of course, it can affect breathing muscles. Now, you'll see on all sorts of myasthenia websites and hear people talking about myasthenia, about this division between ocular myasthenia and generalized myasthenia. And I've always thought that that's a little bit of an artificial division. And I think many of you who are classified as primarily ocular myasthenia will also say that you probably do have a little bit of limb weakness as well, and it's just not as prominent as the ocular myasthenia. Really, the only difference to distinguish between the two is that there are some of the more aggressive treatments that we wouldn't be offering for primarily ocular disease. Not that any of you would accept it. I don't think anybody's going to want to have chemotherapy for a droopy eyelid, but that's the main reason that we distinguish between them. So the asterisk there is because when I say it can affect any muscle, it means any skeletal muscle. Skeletal muscles are the ones that move your limbs, move your eyes, move your face. It does not include heart muscle. That's a different kind of muscle. And it does not include smooth muscle in the bladder or the intestinal muscle. So you don't have to worry when you're diagnosed with myasthenia that, oh my God, it involves the muscles, I'm going to die of heart disease. You're not. Well, you might if you're if you've got heart disease, but not from the myasthenia. And the myasthenic weakness is what we refer to as fatigable weakness. So that's neuromuscular fatigue is this phenomenon where the muscle strength starts out normally, but with each contraction, it worsens. And then if you rest the muscle, it'll improve again. So in other words, the muscles weaken abnormally quickly in myasthenia. And that's the basis for this awful test that we put many of you through where we electrocute you. And these little waveforms here are indicating the amount of muscle that is contracting in response to an electric shock. Usually we check one of the facial muscles, but sometimes we'll do it in the hand or elsewhere. And so if you don't have myasthenia, every time we shock you, boom, 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 these should all be exactly the same size. But you can see here, it gradually goes down. So by the time you get down to the sixth contraction, you're only firing about half of your muscle. And that's just this reflection of neuromuscular fatigue. So that's why we torture you. It's not just to be mean. And neuromuscular fatigability is actually normal. Anybody who's carried something heavy for long periods of time know that eventually your muscles will become exhausted and you have to stop and rest. But obviously that where you have to stop and rest and how heavy a suitcase you can carry is going to be a lot different between an athlete and a myasthenia patient. And the difference between an athlete and a non-athlete average adult is probably relatively small, whereas the difference between the non-athlete adult and a myasthenia patient whose disease is not well controlled is huge. So something really light will become profoundly difficult to lift and carry for any period of time when you've got bad myasthenia. Another pertinent negative is that when we use this phrase fatigue in the neuromuscular world, it's not the same as the use of the same word in the general population. So generally when people say, oh, I'm fatigued, it means I'm tired or I'm sleepy. And in the neuromuscular world, it doesn't mean that. So tiredness and sleepiness per se is not really part of myasthenia gravis. Now, you can have a certain degree of feeling tired when autoimmune diseases are flaring up. And there's a whole bunch of reasons for that. But I always like to distinguish that we're really when we use the word fatigue, we're really talking about weakness. So what are the symptoms and signs of myasthenia? Well, I'll probably go through this relatively quickly because you guys know very well. But in general, any myasthenic weakness, as I've already said, it will worsen with exertion or worsen with the more you use the muscle, basically, and improve with rest. It'll get worse in a hot environment. And this is just a reflection of the normal physiology of muscle. All of our muscles work less efficiently in the heat, but when you don't have myasthenia, you don't notice it. When you do have myasthenia, you might notice quite a bit of worsening if you go into a hot environment, and it'll improve when you cool off. In general, because you've been using your muscles all day, myasthenic weakness tends to get worse towards the end of the day. And of course, the big characteristic is fluctuations are hugely common. So hour to hour, you might wake up at 8 o'clock in the morning and your left eyelid might be droopy. And by 10 o'clock, it might be the right one that's more droopy, or the next day, it may be neither eyelid is drooping, but you got myasthenia mouth, et cetera, and month to month. So it's very fluctuating disease, which is sort of a blessing and a curse at the same time. And this leads us to the next of the pertinent negatives. And I always like to emphasize this when patients are first diagnosed, that this is not a progressive disease. So you're not destined to get worse and worse as time goes by. In fact, quite the opposite. In general, it's not a 100% rule, but in general, the roughest time with myasthenia is the first few years. And then it tends to improve either through treatment or in fact, the myasthenia can actually burn itself out. And there's a small percentage of people where it actually goes away spontaneously. And I always use the expression, it's like your immune system wakes up one day and says, what the hell was I thinking, and stops doing it. Now that happens overall in about 20% of patients with myasthenia. But it's way more common in a certain population. And the population where that is the very most likely to happen are women with negative antibodies whose disease came on in their 20s or 30s. So that's the best group to be. And Marty, I hate to tell you, the worst group to be is men over 50 with positive antibodies. It happens that myasthenia will go away in that group, but gosh, it's rare. On the other hand, it should be very treatable. So sort of already said this, the symptoms start in one of three muscle groups. So the ocular ones, if you look at all myasthenia patients, it's about half of patients' first symptom will be ocular, either droopy eyelid or double vision. If you just look at the ones with positive antibodies, it's about 85%. So this is what it looks like. You guys all know this. So the lid on this patient's right, our left, is normal, and the one on our right, the patient's left eye, is drooping. And I'm hoping this video is going to play. You guys probably wonder what the hell it is I'm doing when I hold my finger up in the air, besides making jokes about Premier Ford. I'm trying to tire your eyelid muscles out. So we'll play this. This guy is going to try to keep, you can see he's got a little droop on both sides, but it's much more striking here. And he's going to try to open that lid up, and you're going to see it float down. So there is a fatiguing eye muscle. And then if he closes it for a second, it improves, but only briefly. You get that kind of twitch, and then it comes down again. So that's what I'm looking for when I make you look at my finger. And then, of course, the other symptom is double vision, which when it's completely double is very obvious that that's what's happening. But very often when the images are not quite so far apart as these wine glasses are, it's not obvious that it's double vision. It just comes across to your brain as blurred vision. And of course, there's a million things can cause blurred vision, everything from dirty glasses to cataracts to just being nearsighted. So the way to sort out if your blurred vision is from the myasthenia as opposed to something else is to just cover one eye up and see if the image sharpens up. And then when you're looking with both eyes, it's blurred again. That's the myasthenia. Whereas all those other causes, of course, that won't make a difference. And when the eye muscles are very weak, it's obvious even looking at someone. So you can see this person's trying to look over to her right, and the right eye moves over, but the left eye doesn't. So that you can actually see that the eyes aren't working in conjunction. A lot of times when the weakness is not quite that dramatic, it will look to me as though your eyes are moving normally, but you'll still be experiencing double vision because they're just slightly off. And in fact, each one of your eyeballs has 6 different muscles moving it in all directions, up and down and side to side and rotating. And so those are 12 muscles that have to be working perfectly in concert with each other for you to not experience double vision. So if one or any combination of those 12 muscles is a little bit weak, you're going to get double vision. The second group is these bulbar, and as I mentioned, these are the sort of speaking and chewing and swallowing muscles. One of my patients calls it margarita mouth. And I think I've told a lot of you the story of the guy that used to work for, I used to not identify the company, but now that they're belly up, I can say it. He used to work for Nortel, and he used to give a lot of afternoon PowerPoint things. And when he finally got his myasthenia treated, all of his coworkers were congratulating him on quitting drinking. And he was so shocked because he didn't drink at all, much less to excess. But I guess he would start out these afternoon PowerPoint talks, and as he went on, he would slowly start to slur his words. So all of his coworkers thought he was hitting the margaritas at lunch. Anyways, that's fatigable dysarthria. Then there's this awful thing called the myasthenic snarl. It's not a very nice name, but it's out there in the literature, and it's really just reflecting weakness of your smiling muscles. So this poor lady, believe it or not, is trying to smile, and you would never know it because it looks like she's snarling at you. And then there's fatigable weakness of the jaw. This is not jaw pain. It's just literally chewing something that normally would be very easy to chew, like a piece of bread, feels more like a cheap steak, that it's very, very tough to chew. And when jaw weakness is extreme, people will even have trouble keeping their jaw closed. The muscles that keep the jaw closed for some reason get weaker faster than the ones that open it. And you can see this guy's trying to look nonchalant by putting his thumb under his jaw, but in fact, he's holding his jaw closed. And another one of my patients from many years ago made this joke to me when I first met him. And he said, you know, when I was a kid, my father told me, son, the secret to success is to keep your eyes open and your mouth shut. And now that I've got myasthenia, I can't do either. So I thought that was a memorable saying. And then, of course, there's trouble swallowing, which we call dysphagia. And that's because your esophagus, your swallowing tube is muscle, and it can get weak just like any other muscle. And then happily, not very commonly, but it does happen, shortness of breath. And of course, there's a lot of muscles involved in breathing. All of your chest cavity is surrounded by muscles. And of course, the diaphragm, which is the bellows, is a skeletal muscle as well. And then about a fifth of the time, patients will not present with eye or bulbar symptoms, but they'll present with limb and trunk weakness. And they're much harder to diagnose because there's so many other things that can cause limb and trunk weakness. So here this lady is trying to keep her arms up. And you can see as time goes by, they start to float down. And you can also notice that her head is starting to go forward. And that's because she's also getting weakness of her neck muscles, and specifically the neck extensor muscles, because they're the anti-gravity muscles, are notoriously affected by myasthenia. When it's very severe, people will present with this thing called the dropped head syndrome, where they can't lift their neck up. So here this gentleman before his blast of Mestinon, and here he is about an hour after his blast of Mestinon, and he can lift his head up. And then the trunk muscles, or what we call axial muscles. And I thank one of my other patients, Wayne, for this image. He was trying to explain to me what it was like having axial weakness. And he said, it's like those air things that they have outside the used car lots. And I thought, what a terrific description. And so when patients have overt myasthenia, you know, they have double vision and droopy eyelids and all that, it's very easy to spot when they're experiencing axial weakness. If that's your first symptom, though, it can be very confusing for the doctors because they start thinking about a symptom called ataxia, which this actually isn't. But once you start thinking of ataxia, you go down the rabbit hole looking for all sorts of terrible things in the central nervous system. And then one day the patient comes in with a droopy eyelid and you think, oh my gosh, he's got myasthenia. So thanks, Wayne, for that image of the axial instability. So if you add all of those numbers up, you'll get 95% of presentations of myasthenia. What about that other 5%? And thank goodness this is extremely uncommon for patients to actually present in myasthenic crisis. And I can think of only 2 of my patients who I first met in the ICU undiagnosed. I can think of a few who have been in the ICU, but we already knew they had myasthenia. But somebody who's had a bunch of non-specific symptoms, but the penny didn't drop until things really came to a crisis. And what myasthenic crisis is when your breathing muscles get severely weak. And if you think about it, it makes sense because if you have a droopy eyelid, you can close your eyes and rest your eyelid muscles. If you have a weak arm, you can stop lifting things with your arm. If you have weak breathing muscles, you can't really stop breathing to rest them. And so you end up not able to get enough oxygen and you end up intubated. And this is another pertinent negative I want to tell everybody just so that they don't worry. I don't think for people who've had myasthenia for a long time, this is a worry, but when people are first diagnosed and they read about myasthenic crisis, it can be quite anxiety provoking because they fear that, you know, I'm going to go to bed tonight feeling fine and I'm going to wake up in the ICU, or as one person said, I'm going to wake up dead. And that just doesn't happen. Myasthenic crisis does not happen suddenly. You get lots of warning. It can happen quickly, but it's usually preceded by a lot of warning symptoms of limb weakness and worsening trouble swallowing and worsening speech. And so when those things happen, I tell all my patients, let me know. And if you can't get a hold of me, go to the emergency room and tell them you got myasthenia, and you go right to the front of the line, theoretically. I can hear Ann Dugan laughing already. But factors that will worsen. Sorry, I said Dugan. There's another Dr. Dugan in Ottawa. It's Duggan. Sorry, Ann.
All good.
So factors that will worsen your myasthenic symptoms, you guys all know this. So systemic illness, and that makes sense, right? Because if your immune system has to ride out like the cavalry to fight off a virus or a bacterium, part of that cavalry are those badly behaving lymphocytes. And so that will lead to a myasthenia flare. It's probably the commonest cause. Problems with your thyroid, either too high or too low, can screw up your myasthenia control. Increased body temperature. So if you have a fever, either from an infection or whatever, or just being in a hot environment, you go into the sauna and all of a sudden your eyelids start drooping again. That's that effect. Hormonal fluctuations. If memory serves, this is something that Michelle knows all about. In pregnancy itself, myasthenia often, strangely, or maybe not strangely, usually gets better in the early parts of pregnancy, but in the postpartum part of pregnancy, myasthenia can really flare up. And so that's a common thing. Emotional upset, doctors blame everything on stress, but in this case, there's something to it. Because think about it, when you're really emotionally upset, your teenage kid is screaming at you or something terrible's happening, what tends to happen is you tend to clench your jaw, all of your muscles tighten up, and all of those things are using up that acetylcholine. So that's going to make your myasthenia get worse. And then, of course, certain drugs. And if you go to any of the myasthenia sites, you can get lists of the drugs. There's a whole bunch of them. For the most part, a lot of them are ones you're not very likely to run into. The exceptions are the beta blockers. So these are quite widely used, mostly for blood pressure, but they're also used for migraine and a whole bunch of other things. And they can make myasthenia worse. And then a bunch of antibiotics, and again, many of them are older antibiotics that you're not very likely to run into, things like kanamycin and amikacin. But these fluoroquinolones down here are still very commonly in use, especially ciprofloxacin and levofloxacin. And they can make myasthenia quite acutely worse. In fact, I have seen them actually sort of push somebody with relatively well-controlled myasthenia over the edge and have them end up in hospital. So you don't really have to remember, but in general, anything that ends in mycin or floxacin should raise your eyebrow. The good news is pharmacists are terrific at catching this. So anytime a clown in a white coat writes you a prescription, ask them, is this okay for my myasthenia? And they often won't know, but the pharmacist usually will. Now, you might notice on this list in small print here is corticosteroids. These are actually drugs that we use to treat myasthenia. And it's on that list because there's a small percentage, it's actually quite small, probably less than 5%, and for some reason, way more commonly in men than women. When you first start your prednisone, it will transiently make your myasthenia worse, usually just for a couple of days. And if all you've got is a droopy eyelid, it's not a big deal. But if you have more generalized disease, it can actually be a big problem. In fact, years ago, when I was a resident back in the 1800s, we used to actually admit patients to hospital to start with myasthenia to start them on steroids. We can't do that anymore because there's no beds. But I usually warn people that this is a phenomenon that they can run into. So who are you people that get myasthenia? Well, I know you like to tell your spouses that you're 1 in a million, but in terms of myasthenia, you're not. You're about 1 in 3,000. So in the myasthenia clinic here in Ottawa, we have probably about, I am guessing, maybe 250, 300 patients between all of the various neurologists in town. Like any autoimmune disease, it affects women a little bit more than men, about a 3-to-2 ratio. And it can occur in any age, literally from childhood to the ninth and 10th decades. I used to always be able to tell everybody that my oldest patient was 105, and sadly he died just before the pandemic, but he did not die of his myasthenia. He died with his myasthenia. The peak is in women in the third decade and men in the fifth decade, but it can be any age. Many people with myasthenia will have other autoimmune disorders, probably about 15%. And the commonest is thyroid disease, but type 1 diabetes or pernicious anemia, lupus, you name it, and it can occur. About 60% of you have family members with other autoimmune diseases, and occasionally it's actually somebody else with myasthenia. It's not terribly common, but here's our next pertinent negative, which is that myasthenia is not inherited directly. So it's not inherited the way having, red hair and blue eyes is, but the tendency to get autoimmune disease does have a genetic component. So newly diagnosed patients always are worried, are my kids going to get this? And I say, the chance is very, very, very low, but they probably have a tendency to get other autoimmune diseases. How is it treated? You guys know all of this. We divide it into symptomatic treatments and disease-specific treatments. So the symptomatic treatments treat just the symptoms of the disease, whereas disease-specific intuitively sounds better because it treats the cause of disease. But as you all know, it's got a lot more complications than the symptomatic treatments. So what I mean by symptomatic treatment in a different context is if you have a brain tumor and you have a headache from your brain tumor, if I give you morphine to treat the headache, it's going to help the symptom of pain, but it's not going to cure the brain tumor. And that's what I mean by symptomatic treatment in myasthenia. This is a drug called Mestinon because it doesn't do anything for what the real problem is, which is these white cells making the antibodies against the receptor. But what Mestinon, or its other name is pyridostigmine, does is it blocks the enzyme that breaks this acetylcholine down. So what that means is at any given moment, there's more of that stuff floating around. And that means that the chance of it finding a receptor that has not been destroyed by the antibodies is higher. So that's how Mestinon works. What's lovely about Mestinon is it's very predictable. So when you do respond to it, the effect usually comes on within about 15 minutes, half an hour of taking it, and it lasts anywhere from 3 to 6 hours. The dose is really variable. I have sort of a standard adult dose is 1 tablet 3 times a day. I have people who take 2 and 3 at a time. I have people who take half a tablet. Everybody kind of works out their own schedule. And what's nice is that the side effects are very recognizable. So if you do happen to take too much, it's pretty obvious what's going on, and then you can just cut your dose back. For some reason, that's not 100% clear. People who have MuSK positive antibodies, some of them respond to myasthenia, but to Mestinon rather, but a lot of them don't, and a few of them actually have a bad reaction to Mestinon. It actually makes their weakness worse. The side effects, you've heard me say this in the clinic, anything that will secrete more. So the big things are runny eyes, runny nose, and runny bowels. Less commonly, if you have bad asthma, it can exacerbate that. If you don't have asthma, it's not a worry. And it does tend to slow your heart rate down. But for most people that don't have heart problems, it's not a noticeable effect. So you might drop your heart rate down from 76 down to 72. But if you already have a tendency to have a slow heart rate, it can drop it down so much that you get dizzy spells. There are other symptomatic treatments I'll happy to talk about more in detail if you want later, but I'll just mention iopidine eye drops is a little trick that I sometimes use, but it works only for the droopy eyelids. Unfortunately, it doesn't work for double vision or anything else. And then just cooling the muscle off will often work, and I'll show you some pictures of that a little bit later. So those are the symptomatic treatments. What about the disease-specific treatments? So this is where we're going to try to do something about this problem with the white cells attacking the receptors. And as I've mentioned, the way they attack are those little missiles there, the antibodies. And I had to start putting this slide in with the pandemic because all of a sudden everybody was familiar with the word antibodies. And of course, in the context of the pandemic, antibodies are good. That's what we want to get after our COVID vaccines. We want to make sure your antibody numbers are up. So should we love antibodies or hate them? Well, the answer is both. And the example I use is that antibodies are a bit like doctors. So most are good or at the very least harmless. But every now and then you run into Dr. Evil or Hannibal Lecter that cause problems. And that's what's happening in autoimmune diseases. You have these bad antibodies that are attacking parts of the body. So I already told you that it's more complicated than that when I drew you my silly little diagram. Now we're going to get a little tiny bit into the weeds. I'm not going to go too crazy, but the immune system really is very complicated. But a way to think about it is that there's a certain subset of those white blood cells that we call lymphocytes, and they're the main soldiers of the immune system. And we divide them into two big groups, the B cells and the T cells. And the B cells are, I don't know if any of you are in the military, but the B cells are the grunts. They're the soldiers that are actually firing the missiles. And in this case, the missiles are antibodies, or another name for antibodies is immunoglobulins. And they look like these little inverted Ys. That's what an IgG antibody looks like. So the B cells make the antibodies to fire against the non-self. Now, the asterisk is there because, of course, in autoimmune diseases like myasthenia, they're also firing them against some normal self tissue, but they don't realize it. It's a mistaken message. But the B cells are just following orders, and they get those orders from the T cells. They're like the generals. There's a zillion different subtypes of T cells, but amongst the subtypes are a group of what we call T helper cells, a specific subset of T helper cells whose job it is to recognize the difference between self and non-self, and then send the instructions out to the B cells to get rid of that non-self. So the good news is that we can suppress the function of both B and T cells with medications. The bad news is when we do so, we suppress all B cells and all T cells. So you have a drop in your immune function in general, and it makes you more vulnerable to infection. So yes, it decreases the production of those myasthenia antibodies and hopefully improves your myasthenia, but it also means that you're much more likely to get into trouble with infections than somebody who's not on them. So an ideal myasthenia treatment would stop the production of the bad myasthenia antibodies without affecting the good antibodies or other parts of the immune system. And we're not there yet, but we're getting closer and closer all the time. So looking at the way we treat myasthenia now and for the last many decades, really, there's a couple of approaches we use to get rid of those antibodies. First is to just use medications that stop the production of antibodies, or I shouldn't say stop, but decrease the production of antibodies. And the number one drug here is prednisone, corticosteroids, basically. And any of my patients have heard me use this phrase, we have a love-hate relationship with prednisone in the myasthenia world. We love it because, gosh, it works well for myasthenia, but we hate it because it's got so many side effects. And the longer you're on it, the more side effects it has. And I can talk in detail about steroid side effects if you want, but sadly, I suspect many of you are very familiar with it. The problem with prednisone and autoimmune disease is, yes, it decreases the production of antibodies, but it does a zillion other things. It affects your bones, it affects your weight, your metabolism, it affects your mood and your sleeping. So it's kind of like a big blunderbuss or a shotgun that yes, does improve antibody numbers, but also does all of these other things. So we use it because it kicks in quickly and relatively predictably, but we don't like you to be on it for too long because you get all these side effects. So we tend to try to move you over to steroid sparing agents, and there's a bunch of them. For many years, the one that we used the most was a drug called azathioprine, or Imuran, or as one of my patients used to call it, the dumbbell pill, because it's got this little double-barreled dumbbell. And it's a terrific drug. We don't use it as much as we used to anymore because it does have lots of potential side effects. If you have side effects, they can be severe, but if you don't have side effects, it's a terrific drug. And it's really been largely replaced by a related drug, kind of its great grandson, a group of drugs called mycophenolate or mycophenolic acid, and that's Cellcept and Myfortic. And they have similar mechanism of action of Imuran, but kick in a little bit more quickly. Any of you who have been on Imuran in the past or are still on it, you would have been told that it kicks in at the very soonest 6 months after starting, and often more like a year. So that's a long time to wait. Cellcept, you still have to wait several months, but it's not quite as long a wait. And then there's a bunch that we use way less commonly, but they all have their place. So methotrexate, tacrolimus, cyclosporin, and rarely cyclophosphamide. So that's the ones that decrease the production of antibodies. Then you can physically remove the antibodies. And the way that's most obvious to do that is something called plasmapheresis, or it's also being called apheresis, or you'll hear it called plasma exchange, or I often put it in my notes as Plex, which is the short version of plasma exchange. And that's where literally they take the blood out of one arm, put it through this fancy washing machine, and then put your own blood minus the antibodies back in the other arm. And it works terrifically well, pretty darn quickly, but it's a temporary fix. So we use it sort of in emergency situations, when people are in myasthenic crisis, or we use it preoperatively when people are going to have a general anesthetic, that sort of thing. And occasionally, unfortunately, people can end up on it for long term, but that's happily relatively rare. You can also neutralize those antibodies either with IVIG or with subcutaneous immunoglobulin. So those are sort of our standard disease-specific treatments nowadays. Now, I wasn't going to put this in, and then I realized, oh, I know somebody's going to ask me about thymectomy, so I might as well put this in. What about thymectomy? And thymectomy is the name we give to the surgery to remove the thymus gland. So to start out with, I'll remind you what the thymus gland does. It kind of sits in this middle part of your chest called the mediastinum, in between the top of the two lungs and in front of the heart. And if you don't have myasthenia, it tends to shrivel up by about the age of 2. Its function is that it helps the immune system mature. So it's very active in the first 2 years of life. And I call it a school for T cells. They're called T cells because the T is for thymus. So those T cells go to the thymus to kind of learn their craft. You can think of it as if I called them the generals of the immune system. This is like West Point for the T cells, or I guess in Canada I should say the RMC for the T cells. So it normally would shrivel up after age 2, but in a significant percentage of people with myasthenia, not all of them, but in many, not only does it not shrivel up, but it can actually become enlarged. So we know that the thymus is implicated in myasthenia. It's not entirely clear exactly how, but there's many lines of evidence that show that the thymus is doing something it shouldn't in myasthenia. So to start with, about 10%, 1 out of 10 people will have something called a thymoma, which is a tumor of the thymus gland. You can see if you're on a chest x-ray, that little bump there should not be there. That's a thymoma. More often, they're not that big and you can't see them on a chest x-ray, so you need a CT scan. Now, 10% of patients have that, which means 90% of myasthenics do not have a thymoma. And about a third of people that have thymomas either have or will develop myasthenia, but that means 2/3 won't as well. Most thymomas occur in people who have positive AChR antibodies, so it's actually extraordinarily rare to see a thymoma in somebody who is seronegative or anti-MuSK antibodies. Having said that, I tend to send everybody that has myasthenia off for a CT scan because I don't want to be lying awake at night worrying, and I don't want you lying awake at night worrying. I don't think I've ever come across a thymoma in a patient that didn't have positive antibodies, but it's worth doing because it's a simple x-ray. So 3 out of 4 thymomas are benign, but 1 out of 4 are cancerous. And the problem is you can't tell by looking at the CT scan which ones are the cancerous ones. And cancerous thymomas can be really awful. They can eat into the heart, they can eat into the chest wall, they can metastasize. So if you're found to have a thymoma, that thing's got to come out. And that's called the thymectomy. So there's zero controversy over thymectomy for patients with thymomas. It's got to come out. Most patients with myasthenia who have thymomas have quite severe myasthenia. And life is not fair because when you do take the thymoma out, you would think, oh, that was what was causing the severe myasthenia. It should get better now. And unfortunately, it doesn't. So it's not entirely clear in the thymoma patients why that doesn't happen. It sometimes will improve, but patients with thymoma, their myasthenia almost never goes into remission. It certainly can be controlled with medications, but they're not amongst that lucky group where it goes away. So that's the patients with thymomas. What about the folks without thymomas? How do we approach thymectomy in those? And that gets a little bit controversial. For many years, it was considered standard of care to send everybody with myasthenia for a thymectomy. And starting kind of in the early to mid 90s, many of us kind of started expressing some skepticism and whether this was working, because we would often come across patients who had chosen not to have a thymectomy and who did remarkably well. And I can think of many of them. So finally, there was clinical trial called the MGTX trial. We were involved with it in Ottawa, and it ran sort of roughly from about 2004 to 2010 or something. I can't remember the exact years. And it followed 126 patients. They all had generalized myasthenia. They all had positive antibodies. None of them had thymomas because they didn't want the data to be contaminated by that. And they had, in order to qualify, they had to have their disease for less than 5 years. And at the 3-year point, it showed that the patients who had the thymectomy did do better than those who didn't have the thymectomy. But gosh, it wasn't by much. This thing called the QMG, which stands for Quantitative Myasthenia Gravis Scale, was not even 3 points different. When if you look at a QMG, 3 points is not a huge difference. And at the end of 3 years, the patients who had the surgery took slightly less prednisone than those who hadn't had the surgery, but they were still on prednisone. So I always express my uh, ongoing skepticism about thymectomy, but I happily refer people to see thoracic surgeons. It's a fairly big deal to have a thymectomy, but the data shows that it probably does help a little bit. So if you have quite severe myasthenia, it's an easy decision to make because any little bit will help. If your disease is actually fairly well controlled with medications, it's a bit tougher of a decision. What we do know from not that MGTX trial, but from subsequent trials, is that there's no role for thymectomy in patients with anti-MuSK antibodies, and it's quite questionable in people with antibody negative disease as well. So the summary then is the stuff that we're using these days is largely the symptomatic treatments with Mestinon or the eye drops and cooling. I put this picture in because I tell people, if your only symptom is a droopy eyelid after 10 p.m. at night and you just want to watch Rachel Maddow on TV, forget the medications. Just get a bag of peas out of the fridge and cool your eye down, and it'll pop the eyelid open long enough to watch your TV show. So it doesn't last for very long, but it can be a helpful thing in certain scenarios. It doesn't do anything for the double vision. And if you cool other muscles off, it will probably help a little. For example, people with the dropped head syndrome, say if they put an ice bag on their neck, it helps a little, but it's also dreadfully uncomfortable to have an ice bag on your neck. So there's a limited role for the cooling, and it's a fairly transient effect. We actually use it as a diagnostic tool, the ice pack test. And then we already went through all of these disease-specific treatments that we use. So what's new in myasthenia? That's the other thing that Michelle asked me to talk about. I wanted to show you this picture of me when I first came to Ottawa, looking for a parking place at the Civic. Haha, that's an Ottawa-centric joke that only people from Ottawa will know. We have terrible parking at the Civic Hospital. So these newer treatments are what we call targeted immunotherapy. Now, I've put quotations around newer because at least one of them has been around for at least 20 years, but it's newer that it's being used a bit more frequently. So the targeted ones that we'll talk about are the B-cell depleting agents like rituximab, what are called FcRn blockers like Vyvgart, and the complement inhibitors Soliris, and then briefly talk about some things that are in the pipeline. So the B-cell depleting agents, this is as of now, rituximab or Rituxan. And it's been around in the cancer world for 25, 30 years. And for that matter, it's been used occasionally in myasthenia for easily 15 years and probably 15 or 20. At least in Ontario, it was remarkably difficult to get this approved for myasthenia patients until about 6, 7 years ago. And now it's gotten a lot easier. So we're using more and more. In some patients, it works really well. Now, we talked about antibodies, love them or hate them. It seems kind of counterintuitive that you're treating a disease that is caused by bad antibodies with a drug that is, in fact, itself an antibody. So it's a man-made antibody or a monoclonal antibody that's directed against B cells. They have a little surface protein called the CD20 antigen, and it's like their Achilles heel. So these antibodies directed against the CD20 protein kill off the B cells, and the B cells are the ones that are making the bad antibodies. So it's an antibody against the antibody factory. Sounds kind of funny. It's given as an IV infusion weekly for 4 weeks. Occasionally, we'll do it at a larger dose every 2 weeks. And for the most part, it's pretty well tolerated. Some people get headaches or flushing or diarrhea. But it's in general works pretty well and is well tolerated. It's especially helpful in patients with anti-MuSK myasthenia, and there's various theories about why this is, but the truth is we don't really know why it works so much better for MuSK than anti-AChR myasthenia. The anti-AChR, it seems to be about 50-50. It either does nothing or it's helpful, but it's not quite the dramatic effect that we see with MuSK. But what's nice about it is when it does work, even if it works incompletely, it lasts for about 6 months. So you have these once a week for 4 weeks doses, and then you're good for 6 months. So it's very attractive medication in that sense. There's some new stuff coming out that targets a slightly different B cell antigen called the CD19, and it's already approved for use in a bunch of B cell cancers called lymphomas. And it's showing some promise in myasthenia, but it's not yet available for myasthenics at this point. Then we've got the FcRn blockers. This is sort of like the big news in the last couple of years. The FcRn blocker Vyvgart was approved in the States in about late 2021 and in Canada in September 2023. And it's been the big news recently. So what exactly is FcRn and why do we want to block it? So again, I'm going to go back to my warning that the immune system is more complicated than my silly little diagram. And the FC in FcRn refers to part of the structure of the IgG immunoglobulin antibody molecules. These are the ones that look like the inverted Ys. I've got an asterisk again there to remind you that there's actually different types of antibodies than just IgG. So there's IgA and IgD and IgM and IgE, and they all do different things in the immune system. But the one that is problematic in myasthenia is IgG. So when we're talking about autoantibodies, we're usually talking about IgG molecules. So IgG molecules have two parts. There's the antigen binding part down here, and this is different from one antibody to the next. So if you got an antibody against measles, it'll have a certain kind of wanted poster here in the FAB arms. Whereas if you have an antibody against COVID, it's going to look a little bit different in that section. You have an antibody against your ACH receptors, it's going to look different. But there's also this section called the FC, or the constant fragment, that is the same in all IgG antibodies. And that FC protein interacts with a whole bunch of different receptors, handily enough called FC receptors, on a whole bunch of different immune cells to do different things to the immune response. So in some cells, they will increase an immune response, and in other cells, they will cause the immune response to be dampened. And in the case of FcRn, it does something that has to do with the lifespan of the IgG molecule. So it's called FcRn because it's an FC receptor neonatal. And you're thinking, that's a funny name. And it's because it was first discovered in the gut of baby rodents. I can't remember if they were mice or rats, but there's baby Mickey anyway. But in fact, even though it was discovered in neonates, it's actually in adult animals and adult humans as well. So it's very ubiquitous, this FcRn receptor. And what it does is it's important in the recycling of IgG molecules. So it's like the blue box of IgG. So what FcRn normally does is it binds to the IgG molecules, but not the other Ig, so not the IgA or IgE. And it protects the IgG from being degraded. So it makes any particular antibody have a longer life. It's recycling. And in general, that's a good thing. So you want your anti-COVID antibodies to have a long lifespan, and you want your anti-measles antibodies to have a long lifespan. You don't want your anti-ACH receptor antibodies that are giving you the myasthenia to have a long lifespan. So that's where these blockers come in. They block the blue box to make the removal of IgG antibodies accelerated. So it decreases their lifespan of the bad antibodies that are causing the myasthenia. Unfortunately, it also decreases the lifespan of the good antibodies. But it doesn't affect IgM or IgG or these other antibodies in the immune response. And in retrospect, after all the years we've been using IVIG, this is probably one of the mechanisms of how IVIG works as well, but it's doing more than just that IVIG. So there are 4 of these right now. The one that's approved in Canada is Vyvgart, and we call it Vyvgart because it's very hard to say efgartigimod. So Vyvgart is easier. There's a drug called nipocalimab, which is the subject of a clinical trial that we're just wrapping up in Ottawa right now, and have had a couple of patients in that, and it's looking very promising. Those are both intravenous FcRn blockers. And then their subcutaneous one Rosanolixizumab, which is called Rosimab, which is slightly easier to say, is subcutaneous. And then something that used to be called Imavant, but is now batoclimab, is another clinical trial that we were involved in Ottawa, and it's a subcutaneous FcRn blocker. And they all work in similar mechanisms. I'll show you the data for Vyvgart because I thought it was quite impressive. So I mentioned already it was approved in September of 2023. Similar in a way to the rituximab, because you get weekly infusions, once a week for 4 weeks on, and then 4 weeks off, and then repeat that cycle times 3. And remarkably few side effects. Few people get some achy muscles or headache, and sometimes the white count drops a little bit, but it's been very well tolerated. And this is from the actual trial. So the red are the placebo patients, and the blue are the Vyvgart patients. And these 4 things are various clinical scales. So the MG-ADL, I'll just show you what they are. So this is an MG-ADL, gives you 1, 2, or 3 points for how bad your talking is, how bad your swallowing is, how bad your double vision is, et cetera, et cetera. And the quantitative myasthenia, they're all clinical scales. The QOL is one the patients do themselves. I am frustrated by my myasthenia, not at all, somewhat, very much, et cetera, et cetera. And so on all of these various clinical scales, you can see that they all got better. Even the placebo patients had these numbers drop a little bit in the course of the trial. And that's why we do placebo-controlled trials, because there really is a thing called a placebo effect. But look at the difference between the way the scales drop in these clinical scales. So it's quite impressive right across the board. And in follow-up studies that continued to show that. When you look specifically at the actual antibody levels, so the actual level of all immunoglobulins, this solid line, and the myasthenia antibody, the AChR, you can see that right away, right with the first treatment in the first week, it starts to dip down and it sort of hits its nadir at 4 weeks. And then as they hit their time back on, time off 4 weeks, it starts to climb back up. This is almost identical to what you would see with plasmapheresis. If you measure the immunoglobulin anti-myasthenia antibodies in patients who've had plasmapheresis, that's exactly the pattern that you see. So it's comparable to plasmapheresis or IVIG. Probably has a bit of an advantage over plasmapheresis because it's only affecting the IgG, whereas plasmapheresis takes all of those immunoglobulins out. So it's been a very helpful kind of bridging therapy that we're really just starting to use right now. The third group are the complement inhibitors. They've been around a little bit longer. I've forgotten exactly when Soliris was approved, but I think it was around 2015 or so, but I may have that wrong. So complement, I haven't mentioned complement before. This isn't the sort of compliment that you guys are always giving me, telling me how lovely I am. It's a complement in the immune system. So this is a series of proteins that their main purpose is to help kill bacteria in your body. And so when complement pathway gets activated, a bunch of proteins latch on to the bacteria and basically help blow them up. And in myasthenia, in a certain type of myasthenia, but not in all types, complement also gets activated. And you can see in this not myasthenic neuromuscular junction, you have these lovely folds in what we call the postsynaptic muscle membrane. Whereas in the myasthenia, the folds aren't so deep and they're all sort of beaten up and battered. And that's the result of complement. Complement gets in there and injures the muscle membrane. That only happens in anti-AChR myasthenia, not in anti-MuSK myasthenia. So this drug, Soliris or eculizumab is its other name, blocks that system. And so theoretically will prevent that damage to the postsynaptic muscle membrane. And I already mentioned not useful for MuSK. In general, it's safe and well tolerated. Now, you heard the tone of my voice there, in general, because although it's not the majority of patients, there are some potentially extremely serious side effects with it, and that is meningococcal meningitis. So this is the type of meningitis that kills people. And the risk is really quite high. It's upwards of, I think the actual number was 13.9%. I rounded it off to 15%. So that's a pretty large percent for such a life-threatening side effect. So that should give everyone pause. what this has resulted in is before anybody gets Soliris, they have to be vaccinated against meningococcal meningitis. But even so, there can be some breakthrough cases. And there's also some experience now starting to be reported that people who are getting their meningococcal vaccinations so that they can have Soliris are actually having their myasthenia flare after the vaccine, but before they get their Soliris. So it's a little bit of an eyebrow raiser that, like a red flag that this drug may have some limitations in terms of myasthenia. It's actually been on the market since 2009 for another very rare disease called nocturnal hemoglobinuria, and it works really well for that. But for myasthenia, I have not been that impressed with Soliris. Again, it's weekly treatments for 4 weeks and then maintenance every 2 weeks. Takes about 35 minutes. But the main side effect is poverty, because it is by far the most expensive treatment for myasthenia out there. In Canadian dollars, it's $720,000 a year. If you all had your microphones open, you would all be going. So that's a major stopper. Now, a lot of these are expensive, and we're going to come back to that. There are other complement blockers out there. Ravulizumab, Ultomiris has been approved for about the last, I don't know, year to 18 months. And it's basically another version of Soliris that just lasts a little bit longer. There's a newly approved subcutaneous injection that's self-administered. It's kind of like Ozempic. It's a self preloaded syringe that you can just shoot yourself up with. But here's the thing, show me the money. These are the estimated annual costs adjusted for Canadian dollars of all of these treatments. So here's Soliris up at the top at 728,000 and Ultomiris 685. Vyvgart's nothing to sneeze at either, $300,000 a year. That's a lot. Then the numbers drop off pretty quickly, but before these guys, before Soliris and Vyvgart, we used to all whistle at Rituxan being 14 grand a year, but it looks like a bargain compared to these other ones. And way down here at the bottom is you can buy a whole truckload of prednisone for about $100. And Mestinon, I made this slide, let's see, 4 years ago. I wonder if that has gone up because, as many of you know, the pharma bros have bought up the rights to Mestinon, and they've pumped the price of the damn stuff up. So it's more expensive than it used to be. It's, of course, nowhere near what Vyvgart and Rituxan and Soliris cost. IVIG and plasmapheresis are harder to calculate because with IVIG, you're not just looking at the product, you're also looking at the IV tubing and the nursing expertise, and same with plasmapheresis. But you can see that this is just a crazy number. So I have not used Soliris for that reason. It doesn't work that well. It's dangerous and it's stupidly expensive. Vyvgart, I've got probably, I'm guessing 5 or maybe 6 patients have been getting it. And all but one, they've been very, very impressed. You'll be delighted to know that none of them are paying for it. We're hopeful that ultimately Premier Ford will sign on and pay for it. But right now, that's not the case. And even the insurance companies are not yet paying for it. But the company itself is actually releasing it on compassionate grounds to some people. And it has been really quite a good product, which makes me very confident that the price will drop. Usually a good product, the price doesn't drop, but it's so good that all of the other pharmaceutical companies are working on Me Too versions of it. So I'm hoping that competition will drop that price down and it'll be more widely available. Now, just a really quick little blurb on the what I call the immune reboot, or this is the stem cell transplants, because we're here in Ottawa, home of the stem cell group of Canada. So this is AHST, which stands for autologous hematopoietic stem cell transplant. And the stem cells are the in the case of hematopoietic stem cells, these are the stem cells in the bone marrow which are undifferentiated and can become any type of blood cell. So they can become a white cell, a red cell, a lymphocyte, a platelet. They can have the potential to be anything they want when they grow up. So these are autologous stem cells. So they're not, nobody's killing any babies for this. These are your own stem cells that we harvest from you. And they've been very helpful in a whole bunch of cancer treatments. And more recently, in the last 20 years or so, they've been used increasingly to treat autoimmune diseases. And it kind of makes sense because in myasthenia or other autoimmune diseases, there's a lot of mistaken messages at several levels of the immune system. So you can kind of think, if we were talking in computer terms, that your system has been corrupted and needs a reboot or a new computer entirely to get rid of those mistaken messages. So how does it work? The first step is we have you in and we collect your stem cells, and it's called harvesting, which always makes me grimace. It sounds terrible, but that's what we call it, harvesting. And then Dr. Atkins and company do the equivalent of putting them in the fridge. He doesn't like it when I say that. He likes that I use the scientific word cryopreservation, but it basically means they put them in the fridge. And then we bring you into hospital and we give you super duper horrible chemotherapy, gigantic doses, and make you really, really, really sick to kill off all of your old bone marrow. So that kills off your ability to make all blood cells. So you make no red cells, no white cells, no platelets. So of course, if you're not making white cells, you've got no immune system. So needless to say, that's a very dangerous time when you're not making those red cells. You can become profoundly anemic. You become profoundly prone to get infection. So quick as we can, we go to the fridge and we get out your stem cells and reinfuse them, where they incredibly find their way to the bone marrow. I don't know how they do. And they basically establish a brand new bone marrow, brand new blood cell factories, and you start to make those red cells and white cells. But these ones don't have the mistaken message about how your ACH receptors are foreign or your MuSK proteins are foreign. So it's a big deal to have it done. I'm not kidding when I say the chemotherapy is super duper. It's really, really powerful chemotherapy, and you're really sick when you have this done. And so for that reason, we haven't done very darn many. We did the very first patient in the world, actually, with myasthenia to have a stem cell transplant was done in 2001. I still get Christmas cards from her every year, and I get an email card from her on the anniversary of her stem cell transplant every year, wishing me a happy anniversary. But we've done 18 in all. We're the biggest stem cell program in Canada. Calgary is the next biggest. They've done 6, and in fact, we've just had a paper accepted with Calgary with our pooled results, so it'll be coming out sometime in the next month or so. And the results are actually pretty darn good. So not quite 90% of people achieve a complete stable remission on no myasthenia drugs. We've had not 100%. Up until a few years ago, I was able to say 100%, and we've not been able to maintain that 100%. So one of our patients with something called secondary myasthenia did have his myasthenia recur. Secondary myasthenia is a rare thing where in this gentleman's case, he'd actually had a previous bone marrow transplant, and his myasthenia is the mistaken cells are actually part of his original bone marrow transplant. It's very complicated, but anyways, his didn't work, and we weren't terribly surprised that it didn't work, because the first and only time we'd ever done a second transplant in someone. And then we had one patient with anti-MuSK who initially did really well and then got Graves' disease, and her myasthenia recurred. And that's to remind me to say that although 89% get a complete stable remission, there's a significant percentage, probably somewhere around about 10%, will develop a second autoimmune disease, but happily they're usually fairly short-lived. So we've seen just about everything in the first few months after a transplant. They often will develop a transient secondary autoimmune disease, and in this lady's case, it was Graves' disease. We've had 2 deaths, but none of them was directly related to the transplant. So one was a lady, one of our very first patients, who actually was having the transplant for a different reason. She had gosh, I can't remember if it was a lymphoma or a leukemia. She had some kind of cancer, and the treatment for her cancer was to have a stem cell transplant. And she also had myasthenia. So we just sort of observed her. She was going to have the transplant anyways because of her cancer. And it worked really well for her myasthenia, but unfortunately her lymphoma did come back and she died of her lymphoma. But at the time of her death, she had no myasthenia symptoms. And then we had another poor gentleman who, while he was waiting for his transplant and was immunosuppressed from all his various medications, got sepsis and died. So neither one of them directly related to the transplant, but still enough to give you pause that we don't want to be cavalier with this treatment, because it's really quite a big deal. Now, there's a few things in the pipeline. In the interest of time, won't go into huge detail, but there's this very exciting stuff called CAR T therapy. So there's two A's in our autoimmune CAR T, but the original treatment is something called CAR T with one A, and it's used in cancer treatment. And Ottawa is actually one of the main centers in Canada doing CAR T treatments over at our cancer clinic. And the CAR T stands for chimeric antigen receptor targeting T cells. And what that translates to is you take your own T cells, so remember these are the generals of the immune system, they're harvested and they basically are genetically reprogrammed to turn around and attack cancer cells. I kind of liken it to the I don't know if you've ever seen that movie, The Manchurian Candidate, where Frank Sinatra is kidnapped and they brainwash him. So this is like brainwashing your T cells to go and attack cancer cells. And it's a big deal. People can have significant side effects from it, but certainly not as onerous as having a stem cell transplant. And for lymphoma patients, it's been remarkably successful. So using that same kind of logic and technology, we're now looking at doing this in autoimmune diseases. So we're taking, instead of using them, reprogramming the T cells to attack cancer cells, we're reprogramming them to attack the T cells that are the ones telling the B cells to go and attack the ACH receptor. That was complicated. Anyways, and this has been done in a few patients. This particular trial from last summer was, I think, 14 patients, and they showed very good response to it, and it was well tolerated. And even in anti-musk myasthenia, they haven't done it in humans yet, but they've done it in mice, and it looks very promising. And we were this first trial here was, or paper here was from the group at Penn and Yale. Yale's one of the big CAR T programs in the world, and we're in talks with them about getting together with Yale to do our own CAR T trial. So we're quite excited about that, but it's not off the ground just yet. So you're probably sick of the sound of my voice. I know I am, but I'll just give you one last little story. As my patients know, I like to tell stories to show you what a long way we've come in less than a century. So this lady is a lady named Jean Wilson, who was at the Lake Placid Olympics in 1932, and she won a gold medal and a silver medal for Canada. But you can see within a year, she had died at the age of 23 of myasthenia. She died in Toronto. So that's just to shall I say, re-emphasize what a severe disease this was before we had all of these various treatments. So here's not just a young person, but somebody who's like athletic and at super duper fitness and still dies of myasthenia. The real tragedy was it was literally about a year later that the first treatment would be introduced over in England by a woman named Mary Walker. Sorry, I've got the dry throat here, in this moment that's being called the miracle at St. Alphege. So St. Alphege is the hospital that she worked at. And she was a resident doctor. So those of you who, when you're in the hospital, poo-poo the idea of residents taking care of you, whoever had this resident taking care of them for their myasthenia was very lucky, because she sort of asked the attending about myasthenia and what the symptoms were like, and she sort of thought it through, and she thought, I wonder if this would respond to a drug called prostigmine, which was something that was used for curare poisoning, and she gave it to her patient, and the patient perked right up, and it was called a miracle drug. And that prostigmine was what would ultimately become Mesonol. So there's my story. Any questions?
Yeah, I'm just going to thank you so much for this really great presentation, Dr. Pringle. And thank you for everyone for attending. We'll take questions in a moment, but I just want to mention that we encourage you to provide us your feedback, whether it's through the survey we sent, or if you want to send us an email at mginfo@mgcanada.org, and we'll be able to, I'm sorry, I just realized I wasn't on camera. Yeah, we'll be able to answer you directly. The survey is anonymous. So, and also just wanted to mention that we will have more webinars in the new year. So check out the Myasthenia Gravis Society of Canada website as we post other events. And of course, I wanted also to mention The medication card with the medication that may be a problem for myasthenia is being revised at this time by Dr. Nicole, and we will be making it available on our website in the new year.